Good afternoon, everyone. ITech welcomes all the participants for today's National Distance Learning Seminar series. Today's topic is Management of White Discharge in Women with HIV, and speaker is Dr. TLN Prasad. Dr. Prasad graduated from Andhra Medical College in 1980 and specialized in venerology and public health. Subsequently, he did numerous courses from WHO, CDC, and University of Washington. He has more than 2 decades professional experience of working with state and central government, NGOs, and development partners. Since 2007, he is with NACO as Technical Expert STI, and currently he is the team leader of National Technical Support Unit, which is a BMGF initiative in India. He has represented India at various national and international conferences and workshops. He has 14 publications to his credit in various national and international peer-reviewed journals. He is a life member of various professional associations, and his passion is continued medical education and epidemiology. We welcome you, sir, for today's NDLS session. I would request Dr. Prasad now to take over the session.
Thank you, Divya. Very good afternoon to all of you. As Divya has already announced, today's topic is management of white discharge in women living with HIV and AIDS. Now, before we go into the management, let us also quickly understand what is this vagina and what kind of environment will be there in the vagina. Because this is very important for us to understand the pathology. So the physiological aspect, vagina is in a dynamic ecosystem that contains approximately 10 to the power of 9 bacterial colony forming units. And normally also there will be a slight vaginal discharge which is clear to white, odorless, and has high viscosity. And this discharge depends on the hormonal cycles which is sync with her menstrual cycles. Normal bacterial flora is dominated by lactobacilli. Of course, there are other potential pathogens also will be there, and disbalance or equilibrium, whenever it gets disturbed, it leads into pathology. Normal environment of vagina is having an acidic pH, varies between 3.8 to 4.2, which inhibits the overgrowth of bacteria. So it is a natural protector. Some lactobacilli also produce hydrogen peroxide, a potential microbicide. Now, overgrowth of normal vaginal flora also happens in certain situations, especially when the hygiene is not good or due to internal or intrinsic causes, and this itself also may sometimes causes problem. Having understood the vaginal environment, now let us see what are the common causes of white discharge in women living with HIV/AIDS. Now, women living with HIV/AIDS and women without HIV/AIDS, the causes are more or less same. Only thing is the frequency and the presentation may vary in a woman living with HIV and AIDS. Now, we can broadly classify these white discharge causes: physiological, non-infective, pathological, infective causes. When you look into the non-infective causes, most common thing is a foreign body, forgotten tampon, which may give rise to an infection and also may cause some kind of a foul-smelling discharge. Ectopy and cervical polyps is another common cause. Then fistulae, usually relating to the obstetric injury. Allergic reactions, caustic chemicals which are used to douche, or even routine antiseptics, if they are not undiluted and if they are being used in the same concentration, probably they may also cause some kind of an allergic manifestation resulting into white discharge. Then a poor personal hygiene, including menstrual ablution practices. They all will cause white discharge in a woman where there is no role for the infection, and these are personally controlled, and if the root cause is addressed, probably no other treatment is required. Another important thing is wearing the nylon undergarments. Nylon undergarments, you say, is associated with persistent or a recurrent white discharge which has no apparent cause. Now, coming to the infective causes of the white discharge, the non-STI or the reproductive tract infections, commonly due to bacterial vaginosis. The second one is candidiasis. When coming to the STI, Chlamydia trachomatis is the most important pathogen which causes white discharge, followed by gonorrhea, trichomonas vaginalis, and herpes simplex. Extremely rarely, trypanosoma pallidum may also cause ulceration on the cervix, resulting into a mild discharge. When we talk about the white discharge, what we are trying to describe is discharge at the orifice of the vagina. The source of the discharge can be either from the vagina, or it can be from the cervix, or in some cases it can be both. Now coming to the management part of the white discharge. Now management of white discharge is nothing different than any other management of a medical condition. Basically what is important here is, apart from a good clinical history, what is also important is to elicit appropriate sexual history using culturally acceptable language and ensuring audio-visual privacy, because these are related to the intimate personal relations and personal behavior. They should, as far as possible, should be explored by a trained individual in a very stigma-free and non-judgmental way, so that he can get an appropriate answers. Now, vaginal discharge per se is a very poor predictor of an STI because of the multiple etiologies associated with that, including physiology. It is not a good indicator to suggest us that there is an STI. Meaning, any woman with a white discharge need not necessarily be having an STI. So this has to be kept in our mind. Now, first and most important thing what we need to explore from the individual patient complaining of white discharge is, what are the various characteristics of this discharge? How much is the quantity? What is the color? And how is the consistency? Does it stay in the undergarment? Is there an odor which is disturbing her or her partner? Since when it has started and how long it is persisting? Is there any cyclical changes? Now, these are the important points which will make healthcare provider to think or immediately differentiate mentally between non-infective causes and infective causes, from a physiological where nothing but of reassurance is required to a pathological where your intervention is required. Followed by understanding the different characteristics of the discharge, we'll also like to explore, is there any exaggerating factors? Maybe it is getting exaggerated just before periods or just after periods or in between the periods, or maybe associated with whenever there is a tampon change or a pad change is there. So is there any other associated factors like history of diabetes? So this also will cause, or a history of antibiotic usage for prolonged time. Probably these are also will aggravate an existing condition. Then the next thing we should explore for, is there any associated symptoms like itching, like pain during intercourse, or a dyspareunia, or a mild ache in the vulval area or in the vaginal area, or is there any burning or irritation while passing urine? These are some of the associated symptoms in a woman with white discharge. Then to explore further, is the discharge is limited only to the lower reproductive tract, or is there any upper genital tract involvement? So please try to find out about the menstrual history, wherein specifically ask about abnormal bleeding. When we are saying abnormal bleeding, we are trying to say intermenstrual bleeding, reduced or increased frequency, postcoital bleeding, or bleeding in continuous manner, in a patchy way on a day-to-day basis. All these comes under the abnormal bleeding. Probably they suggest the pathology at a higher level than in the vagina or at the entrance of the uterus. Then association of any pelvic or abdominal pain made to healthcare provider choose, and if it is there, and if there is a serious infection, the individual may also have a constitutional symptoms such as fever, malaise, and body aches. Once we have elicited these symptoms, probably we will arrive mentally what kind of a complaint is the lady is going to be presenting with. Now the next part is, we also need to find out regarding past and present treatment, especially in a case of vulvovaginal candidiasis. Most of the time the women usually take over the counter medications, and also previous prescriptions they get filled and then they may be using. So it is important for us to explore if there is any treatment history. And when we are examining the woman, please do not forget to have a complete examination of not only the external and internal genitalia, but also anorectum and oropharynx, because there is a possibility of other hidden STIs, which the woman may not be perceiving as a risk, or she may not have a symptom to mention with the healthcare provider. But as a healthcare provider, your examination is incomplete unless until you look into all the three natural orifices: genital organs, anorectal orifice, and oropharynx. Then you try to conduct external and internal genital examination with speculum examination, what we call as a speculum examination. And if you find any lesions in the anorectal area, please also perform proctoscopy. A word of caution here: performing proctoscopy doesn't mean that the woman is indulging in anal intercourse. If there is an excessive secretions coming from the vagina, when the woman is lying down, there is a chance of these infective secretions dripping down and secondarily involve anorectal area. So simple presence of a lesion in the anorectum may not indicate anal intercourse in a woman, but at the same time the literature is also saying significant amount of women, both from the high risk category as well as in the low risk category, will have anal intercourse with their spouse or sexual partner. So because of these observations, it is equally important for us to look into anorectal area also. If you have got a laboratory, or if there is a bedside diagnostic facilities are available, and if you have time and skills, maybe you can conduct wet mounts. Usually we take the white discharge, mix it with a drop of normal saline and a drop of potassium hydroxide, and look under microscope for detection of etiological agents. And you may also consider to take a swab and send for culture and sensitivity at the nearest microbiological laboratory. If your ERT center hospital, where it is located, also has a regional or a state STI lab, you can definitely seek the services of them. Or otherwise, the swabs from the vagina or endocervix is an easy way of culturing and testing, and most of the laboratories has these facilities from the district and above. So those ERT centers which has these facilities available with available resources may consider doing the detailed lab investigation also. But you cannot postpone treatment of the woman pending for the lab results. You can review your treatment depending on the lab results during the subsequent follow-up visit of the woman. So the meaning is your treatment should be at the first contact. The lab test will be for the future follow-up. Now there are a couple of ways of managing any kind of an STI. The most usually what all of us practice is the clinical management, where we try to look into the external genitalia, ask some questions, combine them with our own experience, try to do some minimal examination and come out with some kind of a diagnosis, which we label it as a etiological diagnosis and treat. That is the most common practice, whether we like it or not, but this is how people are doing it. But time and again it has been proved this is the most erroneous way of management. Then the second way of management, which is scientifically correct and very appropriate, is etiological management. You try to find out the causes and then treat accordingly. But we all know etiological management is, though it is a gold standard, it is very difficult. The test may not be available. There is a lot of time required, and patients may not wait for their treatment till the results have come. And moreover, on the top of that, negative test does not exclude possibility of a hidden STI. That means, the kind of test what we use, their sensitivity, the specificity, the predictive value, especially the positive predictive value, they're all very important to consider into the etiological management. Hence, in the light of all this, the best way what the national program has adopted is a syndromic case management. Now, syndromic case management enables any healthcare provider at any kind of health facility, with or without lab support, enables you to offer a treatment at the first contact, which gives by and large a quick results also. And because it encompasses all the possible etiological agents, there is no chance of missing a particular cause, which may be associated with an individual etiological agent. However, what we do, because this is an ongoing academic class, we will also try to see etiological aspects of vulvovaginal management followed by syndromic aspect. Both of them we will discuss, and then we will take some question and answer, some questions for me to answer. Now, coming to the bacterial vaginosis, it is the commonest cause of abnormal discharge in women of reproductive age, can occur and remit spontaneously. It is not an STI, but there is some kind of a link with sexual behavior and personal behavior, especially the habit of vaginal douche with antiseptics, caustic agents, and usage of drying agents. This depends on the socioeconomic background. Once upon a time, bacterial vaginosis was associated with elite class, upper class women, upper socioeconomic background women. But of late, in the last decade, many researchers are suggesting bacterial vaginosis is a very common cause of the white discharge in women of any economic background, more related to the personal behavior and to some extent with the sexual behavior. When we talk about sexual behavior, it is the number of casual partners that is more important role. Then there is a overgrowth of mixed anaerobic organisms which replaces the lactobacilli, thereby eliminating the protective nature which they were inducing. As a result, there will be an increase in the vaginal pH by more than 4.5, making it permissible for the overgrowth of other organisms. And it is also more prevalent and more persistent if the woman living with HIV/AIDS has a significant low levels of CD4 cells. That means during the initial periods after ART initiation, if the CD4 is less than 200, this woman requires probably more frequent checkups and counseling and management. Now, what is the cause of the bacterial vaginosis? Gardnerella species is the most common cause, and it is a commensal in almost 30 to 40% of the women, and usually doesn't manifest any symptoms. This followed by other species like Prevotella, Mycoplasma, Mobilincus, or etiological causes which have been attributed to causation of the bacterial vaginosis. On the right hand side, what you are seeing is a clue cell. It is an desquamated epithelial cell, sprinkled on the top of that like a pepper and salt. This is a characteristic feature what we see in a wet mount, which is a telltale sign of the bacterial vaginosis. Now, what is the treatment? How do we treat bacterial vaginosis? It's a single dose, by mouth, second 1 gram is all that is required. It is safer than oral clindamycin because it has got lots of other side effects, and acidifying gels may prevent recurrence of bacterial vaginosis, but it has to be considered by a gynecologist or a specialist. And remember, because it is not an STI, there is no partner treatment required. If there are female partners to this woman, probably they require treatment, but no male partner requires treatment if the woman is diagnosed having bacterial vaginosis. Now coming to the vulvovaginal candidiasis. This is nothing but of the overgrowth of the candida species, which are otherwise a commensal inside the vaginal micro universe. 70 to 90% of the time it is caused by Candida albicans. In some percentage of the women it is due to glabrata species. Now this has got a bearing in the treatment because we observed some kind of a resistance in the glabrata species than in the albicans, but albicans resistance to fluconazole is also reported frequently in different parts of the country. Now candidiasis is the most common cause of white discharge in a woman living with HIV/AIDS. Because of this, we offer treatment only when the woman is symptomatic and compliance. Most of the time it gets precipitated by use of antibiotics and if there is an associated comorbidity like diabetes. And another interesting observation is it is not associated with usage of tampons or sanitary towels. Now how do we treat this? We treat with a single oral dose of fluconazole 150 milligram. Now usually it is administered along with secnidazole in the form of a color coded kit, the kit number 2, which is a green colored kit. There is no need for partner treatment because it is an RTI, it is not an STI, but you may have to treat the partner. Sometimes they are symptomatic, so we need to explore the symptoms in the partner, the sexual partner. If they may have a balanitis or a balanopostitis, then probably the partner also requires treatment. Now how do we treat? The same kit 2 to both the partners, index case and the partner. Now either you treat the condition with vaginal pessaries or through oral fluconazole, both are equally effective. If there is a vulval symptom such as itching, redness, irritation, we can prescribe a topical antifungal like a clotrimazole, miconazole, ketoconazole. Now next important organism is the Chlamydia trachomatis. Now Chlamydia trachomatis is the most common bacterial STI and most common cause of non-specific genital infection in the woman. It is a common concomitant etiological agent associated with Neisseria gonorrhoeae. In almost 3/4 of the women, it is asymptomatic. And the common symptoms attributable to chlamydia infection is you'll find an evidence of inflammation of the cervix, which we call it as a cervicitis. Sometimes the woman may also complain postcoital bleeding or intermenstrual bleeding or a dyspareunia and a dysuria. There could also be cause for a lower abdominal pain if the infection doesn't get diagnosed and treated early. Now how do we treat Chlamydia trachomatis associated cervicitis? We usually treat with oral azithromycin 1 gram as a single dose. It should be administered under observation in the clinic in the center premises, usually given along with cefixime 400 mg in the form of a kit 1, which is a grey colored kit. Because it is an STI, there is a need to treat all the sexual partners of the index case, especially all those sexual partners in the last 60 days. So this is very, very important. Now coming to the second important cause for the vaginal discharge is Trichomonas vaginalis. Now it usually causes vaginal discharge plus or minus dysuria. It is again a classical STI. We see this around 3 to 6% of the women in India, and it may persist for months to years in epithelial crypts and periglandular areas with periodic manifestation. So there is a possibility of this Trichomonas vaginalis induced vaginitis may keep happening including cervix infection. How do we treat? Now if you see this, if you look into the speculum examination, the cervix in a trichomonial infection is described as a strawberry cervix. If you see this, a mild exudate on both upper and lower lip with a punctate erythematous marks are characteristic of trichomonial infection of the cervix. This is what is described as a strawberry cervix. Now the treatment is a single dose of secondazole 1 gram to be administered along with fluconazole in the form of kit 2, that is the green color kit. Because it is an STI, we need to treat all sexual partners irrespective whether they have a symptom or not. Now coming to the cervicitis part, as we already described that the discharge which is coming at the vaginal introitus may be originating from the vagina or from the cervix. So now we have reviewed the causes, the common causes of vaginal discharge. Now let us also review what are the common causes for the cervicitis. Now apart from that, now chlamydia also can cause cervicitis, trichomonas also can cause cervicitis. Now we are looking into the specific heteroscale agents which has got a primary preponderance to cause cervicitis. Now cervicitis can be either acute or it can be a chronic. It can be a infective or it can be a non-infective. Usually acute cervicitis are infectious in nature. Chronic cervicitis are usually non-infectious in nature. And then infectious cervicitis is usually an endocervicitis. The most common pathogens are gonococci and trichomonas. In the non-infectious cause, it is usually an ectocervicitis or otherwise. The most common cause is herpetic simplex. Now HSV2, herpes progenitalis also can cause cervicitis, which comes under the infectious category. It can cause both ecto as well as endocervicitis. Now how do we treat the bacterial causes of the cervicitis? It is with the kit 1, the grey color kit, which contains cefixime and azithromycin, 400 mg of cefixime and 1 gram of azithromycin, single dose, administered orally, usually in the center itself. This is what is called direct observed treatment to ensure 100% adherence and compliance to treatment. Always remember to treat sexual partners of the index case, especially all those sexual partners in the last 60 days. Need to encourage the woman to come for a follow-up checkup after 7 days because of the possibility of non-resolution of the symptoms or probably a chance of a reinfection. Now how do we treat the viral causes? The kit 5, the red color kit, which we use to treat the herpes progenitalis, is the treatment to treat viral causes of cervicitis. What does it contain? It contains acyclovir, 400 mg tablets. It has to be taken 3 times a day for 7 days. Do we need to routinely treat partner? Even though herpes is an STI, we usually don't offer routinely partner treatment. The reason is very simple, because by the time the woman is manifesting, she might have already infected the spouse or the sexual partner. So the both of them may have a different periods of manifestation. If at the same time of the woman's presentation, if the partner is also having visible signs and symptoms of herpes, we can offer the same treatment to the partner also. Otherwise, routine partner treatment is not warranted because of lack of benefit. Then discharge. Now what could be the causes? There could be many causes for the recurrent white discharge. Most important is, it is a physiological discharge but then wrongly diagnosed as an infective cause and offered treatment. So that is the most common thing. Second, as we discussed earlier, if the woman is having a habit of using nylon undergarments, this is one of the commonest cause for recurrent white discharge. Then incorrect ablution practices. So during visiting to the toilet, if the anal area is not cleaned properly, there is always contamination of the vaginal canal with the fecal material, which may cause introduce candida, and candida may start growing here with causing a recurrent vaginal discharge. Similarly, for the same reason, poor genital hygiene, poor menstrual hygiene may also predispose the woman to have recurrent vaginal discharge. And secondly, and most importantly, if the original infection is due to an organism which is resistant to the primary first line regime of the drugs, whether it is cefixime or azithromycin or fluconazole or secnidazole, then there is a possibility of recurrence of the vaginal discharge. Or when we have not offered a partner treatment, there is a possibility of reinfection and then recurrence. In all such cases, if the recurrences are there, if everything else has been excluded, then the best course of action is refer to a higher center where there is a qualified gynecologist and a dermatovenerologist is available for further investigations and management. Now, if there is a recurrent bacterial vaginosis, the same principles will apply, but then if you look into some of the statistics, nearly 60% of them will have a recurrence following a treatment. The most common risk factors associated with recurrent BV are multiple partners, or a new partner, or oral sex, or insertion of the intrauterine contraceptive device, or the usage of condoms, consistent and correct use of condoms, and the usage of combined oral contraceptives are associated with decreasing the risk of acquiring the BV as well as recurrence. Now, coming to the recurrent vulvovaginal candidiasis, when do we call the woman has a recurrence? If there are more than 6 episodes of symptomatic, culturally proven candidiasis in 12 months period, then we can label that woman had recurrent vulvovaginal candidiasis. Then the treatment is a suppressive therapy for a period almost as a period of 1 year with fluconazole. We start with 100 milligram a day and probably combined with intravaginal pessaries along with counseling and a good training to have correct ablution practices. Now, always when you are managing STI or RTI, we need to remember 6 C's. First and foremost, counseling and education of the patient. This is very important to increase the knowledge, to remove the myths and misconceptions. The second is the contact tracing. Contact tracing means all her sexual partners need to be motivated to seek the services and take appropriate treatment. This is what is comes under the contact tracing. Now, if there is a resource available, if there is if the index case has a consent, probably we can send the peer groups to trace the partners and then motivate them to seek these services. Then do not forget to demonstrate and promote condom usage correctly and consistently, and provide condom pieces till the woman access for follow-up checkup. Ensure 100% compliance with treatment. The best way for ensuring this is administer single dose regimes in the clinic setup itself, and ensure 100% follow-up is happening, and ensure in the follow-up, make sure, ask the individual whether the tablets given were completely consumed or not, and ask them to get back the empty file so that we are sure that the individual has taken all the 7 days of acyclovir. And follow-ups are the best classical examples of a good rapport between the client and the service provider, and also enables us to document the impact of our treatment, that is the cure of the patient, unless until the patient is infected with a resistant organism. Now, the management of white discharge in a woman living with HIV/AIDS and in any other woman can be difficult because of so many reasons. The most important reason in a low to middle income group of countries such as ours is non-availability of lab testing. Even if there is a lab test is available, lack of time and adequate skills to utilize them. So most of the time we resort the diagnosis based on symptoms mostly, and sometimes trying to explore the science. The second is infections are impossible to differentiate even by a specialist, highly trained providers, if you follow only signs and symptoms between one to another cause. And there is always a possibility that the patients before coming to you might have had treatment either by self or from different providers. All the treatments has a bearing on the symptoms with which the individual presents herself to us. So there could be a complex way or there could be an altered way of the presentation, which will again cause a difficulty in currently identifying. Now, having said all the etiological, having discussed about the etiological management and all, now quickly review the syndromic way of managing the vaginal discharge. Before we try to understand the syndromic management of vulvo-vaginal cervical discharge, let us understand certain facts. This syndrome is poorly correlated with the major causes of cervicitis, that is gonorrhea and chlamydia. That is the most important thing. Now, most often it indicates vaginal infection rather than infection of the cervix. Okay, and we have already learned the most common causes of vaginal discharge are bacterial vaginosis, trichomonas and candida. And previously the providers used to believe if the color of the discharge is yellowish, which is surrogate for a active inflammation and may be suggesting as an STI, but the literature said it is not so, and it is more commonly associated with non-sexually transmitted agents rather than STI. Many women with cervicitis may not have vaginal discharge or lower abdominal pain. They may have so scanty discharge it may not travel through the vaginal canal and doesn't manifest at the introitus at the time of inspection. And it is been misused as a screening tool in many settings. If you go to any gynae OP and ask any woman, do you have a white discharge? Probably half of them will say yes. Now what is the serious outcome of this? If you only ask a question and diagnose and treat, there will be a massive overtreatment of women for STI, which she may be not having at all. Then there is some evidence that syndromic management of vaginal discharge can be improved if you ensure speculum examination and inspect the cervix and then look for either cervical discharge or inflammation. But this kind of activity requires some kind of skill, some kind of training, some tools and adequate supplies, and more importantly the time, which is the most precious in a busy schedule in a OP, unless until all of these are available, and most importantly the woman must give consent, and we must have, if the healthcare provider happen to be a male, there must be always some support staff available while doing internal examination. Never conduct an internal examination of a female by a male healthcare provider without presence of a support staff. Now, how can we overcome the limitations of the syndromic management of white discharge? Because in a program mode, syndromic case management is what is universally followed irrespective of the level of health system, which also applies to the ART center. So by following certain things, probably we can improve the sensitivity and specificity of the syndromic diagnosis. First and foremost, tailor your approach according to your clinic setting. Consider how much of an exam you are capable of doing very well. whether or not diagnostic tests and effective treatment is available with you or not. If you do not have the adequate skills, please don't do internal exam. You may refer the case, or you may try to offer the treatment to the extent to the best of your knowledge, or you may seek the support and services and advice from your senior colleague. Consider the reason why a woman is coming to the clinic. Does she have a vaginal discharge, or is she coming for some other reason? Is she going to have some kind of a procedure, maybe an abortion, maybe a loop insertion, something like that? If that is the case, if the proper sexual history has not been done, proper inspection has not been done, proper treatment is not offered, she is at an increased risk of getting infected or ascending infections from the lower reproductive tract to the upper reproductive tract. Assess the risk of having an STI in any woman with white discharge. If you suspect a risk based on her or her spouse's symptoms, occupation or behavior, then treat her for cervicitis and vaginitis. And always ensure treatment of all her sexual partners in the preceding 60 days. Even if there is a history of a protected encounter, please offer the partner treatment. If you have time and privacy, and if you are also having necessary skills, then you should be able to do a thorough examination of genitalia, including internal and external and per-abdominal examination, bimanual examination, and try to elicit cervical motion tenderness, which is a very sensitive marker of cervicitis. Otherwise, treat vaginal discharge as vaginitis only. That means with kit 2, do not administer kit 1. If you firmly believe there could be a possibility of cervix infection, but you are unable to do internal examination, then please treat both for cervicitis and for vaginitis, that is with both kit 1 and kit 2. Okay. If you ensure these basic principles, probably the sensitivity, the specificity, and the positive predictive value of your syndromic diagnosis of white discharge will be much more. And these are the minimal things which are within the domain of many people. Now let us see the flow chart. Flow charts are management tools. It enables you to quickly take a decision based on the direction the flow chart is directing you. We already learned the most common causes of the vaginal discharge: Trichomonas, Candida, and Gardnerella, and Mycoplasma. Common causes of cervicitis is Neisseria, Chlamydia, Trichomonas, and herpes. You take including menstrual history, and then you have an examination including your per speculum examination, and then do a bimanual pelvic examination and a speculum examination. Okay, and if there is a trichomoniasis, the discharge is described as a greenish frothy, and if it is a candidiasis, you are expected to see a cardi white discharge, and in case of a bacterial vaginosis, the discharge is scanty, usually adherent to the vaginal walls, and then you may have a typical order when you combine the vaginal discharge with a drop of potassium hydroxide, what is described as a whiff test. Okay, when you do a speculum examination, probably you may see an erosion in the cervix, or an ulcer, or a frank mucopurulent cervical discharge, or a scanty mucoid discharge with or without follicles, punctate erythema marks on the cervix, which are all indicating for us that there is a cervicitis. Okay. If the speculum examination is not possible, or you do not have the speculum, or you do not have the skills, or if the patient denies, but you are sure that there could be a possibility of both cervix and vagina is infected based on the history of her and her partner, then treat her both for vaginitis and for cervicitis. If there is a laboratory test, if the laboratory is available, if you have a microscope and slides and cover sleeves, and if you are reasonably trained, then probably the simplest test what can be done in a ART setting is a wet mount microscopy. You take a drop of discharge, mix with a drop of saline, and another drop of discharge and mix with a drop of potassium hydroxide. look under the microscope, and you may be able to see a motile trichomonads, clue cells, and then maybe you can also see the candida. And if you have a gram stain, the gram stain of the vaginal smear may demonstrate clue cells, which is a classical feature of the bacterial vaginosis. And gram stain of endocervical smear, though is a very crude and a very less sensitive way, may be sometimes helpful for us in enabling to detect intracellular diplococci. Now, how do you treat? Now, the treatment is same as we have already discussed. Now, secretizole 2 gram by mouth, single dose, or if you do not have secretizole, you can alternatively also treat with a tinidazole, but twice a day, 500 mg for 5 days, and probably may also need to give metoclopropamide to half an hour before administering the drug to prevent gastric intolerance. But however, secretizole has got the least gastric intolerance. Treat for candidiasis with fluconazole 150 mg or local clotrimazole pessaries 500 mg once a day. If both vaginitis and cervicitis are present, as discussed earlier, you may administer both kit 1 and kit 2, and then you have to instruct the client to avoid douching, and then if the individual is also had a comorbidity with diabetes, or if she is all carrying, that is if she is pregnant, maybe these are the exaggerating factors, they should be considered whenever you are thinking about recurrence. And please ensure that she visits to you after 7 days for a follow-up. Okay. And for cervical infection, again it is a kit 1, cefixime 400 mg and azithromycin 1 gram. And ideally should be taken 1 hour before lunch, but the program experience says irrespective of the lunch it can be administered in the clinic setting. And if there is a vomiting within 1 hour, probably we have to give an antiemetic and repeat the entire dose of cefixime and azithromycin again. Now there are certain specific guidelines one need to remember whenever you are managing white discharge in a pregnant woman. Now, per speculum examination should be done to rule out pregnancy complications like abortion, premature rupture of membranes, and the treatment of vaginitis in a woman in the first trimester of pregnancy is local treatment. Oral fluconazole is contraindicated in pregnancy, though metronidazole is approved, but we may need to use a caution in uses of that. In second and third trimester, oral metronidazole can be given, and tablet secretizole can be given either a single, probably with or without metoclopropamide. Now, how do we manage a pregnant woman with cervicitis? Then this is managed by cefixime, single dose, or if you have got a ceftriaxone available, 125 mg by intramuscular injection. Instead of azithromycin, probably we may need to give erythromycin 500 mg 4 times a day for 7 days, or capsule amoxicillin 500 mg 3 times orally for 7 days to cover the chlamydial infections. Quinolones and doxycyclines are contraindicated in pregnant women. Now, we have completed both etiological management and syndromic management of vulvovaginal candidiasis. We've also discussed about the commonest symptoms, the common signs, the partner treatment, the follow-up visit, and what need to be done, what need to be counseled. Now, this concludes our session. Now, the floor is open for any questions. So, if you have any questions, kindly do shoot them out. Let us have a discussion. Right. Yes, bacterial. There is a statement made by one of our colleagues. Bacterial vaginosis is associated with increased incidence of transmission of HIV. Now, it is not only, these are not the increased incidence. The bacterial vaginosis, the reproductive tract infections, are also attributed as catalyst for enhancing the efficiency of transmission of both HIV and other STIs. They also have. If already they are infected, they may have a better efficiency of transmitting that because they may enhance at the local level the HIV viral load. And not only that, they are also being, that is the reason apart from STI, we also need to focus on reproductive tract infections. In fact, sexual and reproductive health among the women living with HIV/AIDS is a very important activity one needs to provide, which includes not only diagnosis and management of STI and RTI, but also meeting the unmet needs of the fertility control, empowering the woman with respect to control her pregnancy, the fertility, and then we need to instill in her condom negotiation skills. Sometimes she may be in disadvantages. So all this will help a already infected individual not transmitting her infection to others, and if an uninfected individual not acquiring the HIV. Now, diabetes mellitus is a predisposing factor for candidiasis. Yes, it is one of the predisposing factor for candidiasis. Now, candidiasis, whenever we are talking candidiasis is a pathological state. Candidosis could be a physiological colonization of the vagina. The most common cause is, a poor ablution practices. So, inadequate and improper ablution practices. And whenever they clean the anal area, how they are cleaning and how it is being kept free is also equally important. And similarly, the way they maintain the menstrual hygiene is also very, very important. Apart from diabetes mellitus, malnutrition. Of course, the most important cause for a recurrent vulvovaginal candidiasis is HIV itself. In fact, this is one of the marker. Any woman who is in reproductive age has recurrent vulvovaginal candidiasis. If she is not already tested for HIV, first step is we have to educate, counsel, and ensure that she is screened for HIV. So that is the most important thing. So apart from HIV and diabetes mellitus, malnutrition, malignancy, and excessive or a prolonged use of antibiotics also associated with vulvovaginal candidiasis. Now, reason for recurrent white discharge and lower back pain even after 15 days of treatment for candidiasis. Now, lower back pain may or may not be associated with candidiasis. Lower back pain usually associated with lymph nodes involvement in the pelvic fossa, which is indirectly getting inflamed because of the chronic infection in the upper reproductive tract. Probably it is a chlamydia, it could be chlamydia, gonococci, or it might be minor pathogens like mycoplasma. These are causing a low grade fallopian tube infection, which is causing glandular hypertrophy and mild subclinical inflammation in the lymph nodes in the pelvic fossa, which causes adherence and which causes the lower back pain. This is the most common cause. Now, whenever a woman has got a lower back pain, which is not understandable, she requires both counseling, treatment, and a good physiotherapy exercise part of that. Probably she requires a better and a detailed investigation also. Then recurrent white discharge. Now please ensure that it is not a physiological. The recurrent white discharge, there is a persistent foci of infection. Either the compliance to treatment is not there, or the infection could be due to a drug resistant causative agent. Either of these two has to be done. And apart from the vaginal introitus, please ensure there are so many small glands in and around the urethra in a woman also, and in and around the opening of the vagina. Now these glands are also sometimes foci of the infection, which causes persistence of the infection and recurrence. That needs to be explored. Do chronic cervicitis increases the risk of carcinoma cervix? No, actually the carcinoma cervix, the most common cause is oncogenic strains of human papillomavirus. That is the most common cause, which again depends on the prevalence of that in India. India, the evidence says we lose around 500,000 women to carcinoma cervix, and most of that is due to oncogenic strains of human papillomavirus. Now, chronic cervicitis per se may not be causing a carcinoma cervix, but chronic cervicitis itself is a smoldering cause. We need to find out the causes for the chronic cervicitis. That is far more important. Any woman after 30 years need to undergo once in 2 years a pap smear. A pap smear is the easiest preventive checkup one should be able to offer, including women living with HIV/AIDS. and once she crosses 40 years, every year it should be done. Okay, unless until we introduce the human papilloma virus vaccination, which is widely practiced in many other countries for adolescents, we may not able to see a community level decrease in the incidence and prevalence of carcinoma cervix. But to quote that the chronic cervicitis directly may not be relevant in promoting towards carcinoma cervix. Now, a sentence about HPV infection of cervix. I think we had now a reasonable discussion on HPV infection. Now, this HPV infection, by and large, in the last 20 years, the program data is suggesting we have around 1 to 2% clinically manifest HPV, both among the women and men. And we do not have much of a data on HPV infection among the PLHAV. It is not being routinely captured, and then probably it may be there. And the second, the visible HPV lesions disappear the moment the CD4 goes up and your ERT gets stabilized. So most of the time, I think it is not been there. But what is important is, apart from the visible HPV, what is the commonest prevalence of these oncogenic strains of HPV? Now that we have got a very patchy data, we do not have that. The only thing we know, the end result of the HPV infection in women, we know that we are losing about 500,000 women due to carcinoma cervix, which is a preventable STI in India. So the need of the hour is to introduce vaccination. The program is also seriously considering and having negotiation with the counterparts. So coming back again, please ensure any woman, irrespective of her HIV infected or non-infected, once she touches 30 years, she is ideally need to go once in 2 years a pap smear screening at the nearest thing. It is a very simple thing, and probably ART centers can initiate this and then get the slides examined by a qualified cytopathologist. Or in case if there is a NCD clinic, non-communicable disease clinic is operating in your hospital or in the hospital where ART center is located, you better have a good linkage with them and ensure that these women are getting periodic regular screening through pap smear, and it is the easiest way what can be done. The second thing is we can also do a acetic acid testing, that testo whitening test, but again it is little to purposes to identify altered or carcinoma prone areas which are subjected for a biopsy. Okay, but please ensure your preventive screening should always result into a meaningful action. That means you should have a good linkage with the next level service provider, and then only there will be a buy-in by the community. Okay, wet undergarments increases chance of vaginal and cervical infections. Yes, absolutely. But what kind of infections we are talking? Not STI. That could be due to RTIs. No, this is iatrogenic infections. This comes under the poor personal hygiene. The same thing. Role of pap smear. I think we have discussed enough on the role of pap smear. And this is the global guidance, and even the NCD, non-communicable disease department guidance also in India, and these are prevalent in some 200 centers, and there is no harm if you can start doing this as a movement across the ART centers, and all those women living with HIV/AIDS accessing your center, and all those women, even if they are not infected, if their spouse is infected, the serodiscordant woman, if she crosses beyond 30 years, please ensure that she gets a periodic pap smear screening at least once in 2 years. She'll till touches 40 years of age, and once she crosses 40 years, she should have annual screening. I think but then the point here is you should learn how to collect a pap smear, or you should able to have a linkage with a facility where pap smear is done. That is far more important. And then please document them in your white cards, and it will generate as a wealth of data, and it will also enable us to understand the kind of events which we are seeing. HPV can cause cervicitis, which may manifest as white discharge per vaginum. Probably yes. We are not saying no, but then more than that, if there is any wart in the HPV in the external area, that is also equally important, and especially if there is a pregnancy is associated. And please ensure a elective cesarean section. Supply of condoms. The condoms are the free supply of condoms are there. If not available in the ART, please try to get from the nearest ICTC or the STA clinic, and and then please appraise the DAPQs. They will try to relocate from some other center where they are available in excess. Most sensitive test for VV is pH paper. Maybe again these investigations or the sensitivity and specificity varies across. That number one. Number two, when you are testing for a pH paper, you must have short range pH paper, that is between 3 to 5. These are commercially available. And then you must be able to use a speculum which is not been what you call treated with any antiseptic, and the discharge which is coming from the vagina without touching from the cervix, there you need to use the filter paper to determine the pH. Though it is easy to say all this, and it is being practiced widely in majority of the skin and beauty clinics, and then in some gynae clinics, if it can be done, it's fantastic, it is very good. But then there are also so many newer point of care tests coming into the market, and we are also trying to explore whether it is any feasible to introduce them in a program mode. So thank you very much for having me in your class, and I hope you all enjoyed. Thanks a lot and have a great evening. Thank you.
Thank you, sir, for